Hello, and welcome to this edition of Neurology Video Journal Club. I'm Bob Fox, staff neurologist at the Mellen Center for Multiple Sclerosis and vice chair for research of the Neurological Institute at the Cleveland Clinic. And joining me today is Mandy Leonard. Mandy, would you introduce yourself?
Sure. Thanks so much for the opportunity to be part of this virtual journal club. My name is Mandy Leonard. I am a pharmacist at Cleveland Clinic, and my specific role is I'm the Senior Director for Drug Use Policy and Formulary Management. So the study that we're discussing today is costs and utilization of new-to-market neurologic medications, with the lead author being Dr. Evan Reynolds from the University of Michigan. So Bob, can you set us up for what the setting of the study is?
Yeah, so neurology has seen an explosion of new therapies in recent years. Almost every field of neurology has had brand new therapies come to market. Some of them are incremental or another version of the same class, and others are brand new classes or first-time treatments for conditions that really we didn't have any treatments, or the treatments were really just symptomatic and not very effective. But with these new therapies, of course, come costs. And the related all important question, are the costs worth it? Are the costs of these therapies worth the benefit that is coming from those therapies? Well, in order to start getting our arms around this question, the American Academy of Neurology's Health Services Research Subcommittee commissioned a group to study this. So Mandy, tell us about what they did.
Sure. So Reynolds and colleagues compared the utilization and cost of new-to-market medications. And their definition of new-to-market medications were those that were FDA approved between 2014 and 2018. And they compared those to existing guideline-sponsored medications for 11 neurologic conditions. So some of the examples of the conditions that were included would be things like MS, ALS, myasthenia gravis, Huntington disease, and migraines, to name a few. And what they did was they utilized a pharmaceutical claims database. Specifically, this was from Optum, and Optum's specific database is known as ClinInformatics DataMart database. And so what they did was they looked at information within this database and calculated the median out-of-pocket and standardized total cost for 30-day supply of specific medications. Additionally, the authors measured the proportion of patients receiving these new-to-market medications compared with the existing guideline-directed medications for these specific neurologic conditions. And so, interesting on what they did. So, Bob, what did they find?
So they looked across 11 different neurological conditions and looked at the utilization from this database over a long period of time as well, from 2004 to 2019 for most of these indications and these therapies. And what they found is that the proportion of patients that were using newly approved therapies over the first couple years of their FDA approval was actually quite small. Less than 20% of the market utilization or the disease utilization of drugs went to these new therapies over the first few years after they were approved. One condition was tardive dyskinesia, where the new therapy was a little bit higher, but in general, it wasn't very high. Importantly, out-of-pocket costs, though, were much higher with the new-to-market drugs than the older guideline-supported drugs, despite, at least according to the authors, similar efficacy of these drugs compared to the guideline-supported drugs. And we'll probably get back to that in a short bit. Here's an example from my field, multiple sclerosis. What we can see on the right side is the utilization of the many different FDA-approved MS therapies. The dotted lines are the older therapies, and the solid lines are the newly approved therapies. And for this study, the newly approved therapies was PEG interferon beta 1A, the trade name Plegridy, and ocrelizumab with the trade name Ocrevus or Ocrevus. And so what we can see is that these therapies were utilized a little bit more ocrelizumab than the pegylated interferon, and their use gradually increased over a couple years, but they still were not used at a higher proportion compared to some of the older therapies. Now, this axis is not easily translatable because to our clinical practice, because it's a log scale, which is a little bit unfortunate, but probably that's the only way they could really show and compare these drugs. But nonetheless, one can see that there was a gradual increase over time of these therapies, but not jumping beyond the older therapies that have been long in use. We can see on the left side the out-of-pocket cost, and they varied widely from therapy to therapy, and they also varied quite a bit from year to year. This was quite surprising to me that from one year to another year, the out-of-pocket cost that patients are paying or are not paying or attributed to them are varying quite a bit from year to year. And we see that that doesn't differ too much, the old therapies to the new therapies. Now, in contrast, we see on the next slide here the use of migraine therapies. So the utilization of the newer migraine therapies, that being the monoclonal antibodies, jumped up a fair bit, but still not as much as some of the standard guideline recommended therapies. But the out-of-pocket costs were quite a bit high. So we see on the left side that the out-of-pocket costs for these new monoclonal antibody therapies were much higher than all of the standard guideline therapies, with the exception of Botox, which also had quite high out-of-pocket costs. So Mandy, what else did you find interesting here?
Yeah, so to kind of tag along with what you're mentioning in slide 3, which shows table 2 in the article, which talks about the utilization and cost, both out of pocket and total standardized cost of the new medications compared to the existing guideline treatment. Really what I was interested in is I really wanted to look at the myasthenia gravis portion of this chart, which is at the top. And I focused on the right-hand side where it talks about the standardized total costs for a 30-day supply. So in this study, they had to kind of normalize everything because some drugs are given a little bit more frequently than others. So looking at the standardized 30-day cost, and interestingly enough, eculizumab or Solaris had the largest median standardized cost for a 30-day supply, with the median being about $55,000. And ranging anywhere from 52 all the way up to close to $60,000. And when you take a look at this, what the drastic comparison is to some of the older, what I would say existing guideline directed therapies, such as something like prednisone, which, looking at is about $9, or something like cyclosporin is about $524 for the median. So it does show kind of the difference between these newer to market medications compared to existing therapies. There could be multiple reasons for that, including some of these are available generically, so on and so forth for that out-of-pocket expense. Also, if you take a look on the slide, we also highlighted the tardive dyskinesia. We're looking at the standardized cost as well as out-of-pocket are also highly variable, noting some of the dramatic differences and just looking at the 25th and 75th percentile for some of the medications like deutetrabenazine and tetrabenazine as well. Those drugs can be a mouthful to say sometimes, but with that. So just interesting to look at the dynamics of the differences within these medications.
Yeah, they're very different.
Yeah, very different.
So, okay, given that, that's what they found, or the highlights of what we see in this. It's a very dense, and there's a lot of data and a lot of information on many different conditions and drugs. What surprised you about what they found, Mandy?
Yeah. So I think when I first got this article, I thought what I would see is that the new to market medications would be used much more than the guideline directed therapy. That was just my assumption. Maybe it was a pharmacist perspective, going into it, but just interesting that really the greater proportion of patients were still being prescribed the guideline directed therapy, except with a few exceptions, which we mentioned a little bit earlier. I know in my role that I have here at our organization, usually as soon as a new medication is approved by the FDA, I'm getting requests for us to evaluate it for formulary, because obviously we're looking at the things that are coming out, the latest and the greatest. But as you know, new medications, sometimes we look at it for, maybe better efficacy or better tolerability, or maybe there's extended dosing, which might help with patient compliance. Maybe something's oral versus IV. So there are many, I think, factors to consider with that, which was hard to kind of determine within this study. They did what some of the reasons are for the certain kind of prescribing patterns within here. It also surprised me the variability of some of the out-of-pocket costs for some of the medications. So something like nusinersen, for example, kind of looking at the 50th percentile kind of being at 40 cents, and the 95th percentile was $16,000. So that is
Wow.
great variability, between there. So I think, as you mentioned earlier, it's really hard to tell, probably as a prescriber, where that patient is going to fall within that spectrum of what their out-of-pocket or their standardized 30-day costs might be.
And then it
For
changes
them.
from year to year, right? So
Correct, which
we
you
see on
mentioned
those
earlier.
charts that, one year it's this, another year it's that. And
Yep.
come January, we don't really know what our patient's out-of-pocket copay will be.
Correct. Because, as you just mentioned, that can change year to year. And even the same thing with eculizumab or Solaris, there could be, differences of the 50th percentile was about $91 and the 95th percentile was close to 4,000. So just another example of the variability. I think often we sometimes become numb to these costs. So I think this study is a good reminder to us about the financial burden that's placed on patients and their families, for the prescribing of these medications. And even though they may not pay the full cost, there are some costs associated, if there aren't other programs available to these patients. And the only other thing, the last thing that I'll say is I could not tell from this particular article is that whether this database that was used, were these just claims? Were these adjudicated claims? Were these prescriptions that were filled? Because as you know, as a prescriber, Bob, you can prescribe something, but that doesn't always necessarily mean that the patient will go to the pharmacy, or does it get sent to a specialty pharmacy, or there are issues or there are problems. So I think, to me, one of the things I'd want to know if these were actually filled prescriptions, for these patients. I think that might also help us put it into a little perspective. And then the other thing that we know, unfortunately, with the costs of medications, some patients may try to extend their medications by maybe having pills in half, or not taking the dose every day, or, things of that nature, which we would never recommend, because we want patients to follow, what was studied to have the best possible outcome. So that was just something else that I was thinking of, especially from a pharmacist perspective.
Yeah, and I was also a little surprised that there wasn't more penetrance of the new therapies, particularly some of the new therapies that we think are more effective, that we think have a better efficacy, safety profile, not just necessarily ease of administration once a day rather than twice a day, but things that have less side effects, things that have greater efficacy. But there is a balance. It also, I think, is a reminder to us as clinicians that when patients are doing well on a therapy, they're probably going to stay in a therapy, and us as prescribers are probably going to keep them going. The "if it ain't broke, don't fix it" sort of philosophy our patients and providers ascribe to. And if a condition, if a symptom, if a neurologic issue is being controlled by something, you can tell me something is better, but if they're already doing well, why change to it? In multiple sclerosis, we look for having no relapses and no new lesions in MRI, and hopefully no progression in clinical disability. And if they're doing that, well, then another drug is not going to do it better because it's already being fully controlled. The disease is fully managed by the current therapy. And I think that's a lot of what the persistence of the older drugs are across the spectrum of these diseases, is that things are working relatively well, at least well enough for patients that they don't want to go and change things.
And that's an interesting point, because maybe as you take a look at maybe the time frame that they looked at this, was there something that was like new to class? So something like nusinersen, that there was nothing available, out there for that.
Right.
So I think that's a really good point of, as I agree with you, if it's not broke, don't you don't need to do anything, to that, keeping the patients on maintaining them on what works for them. So, some of the things maybe to dive in a little bit, deeper, but it's good to kind of have us formulate those questions to think about.
Yeah, and this certainly was a big undertaking, but to mix all of these diseases together, all these neurologic disorders, and whatever drugs were coming to market, it's a little bit apples and oranges, or comparing green and the color nine, things that don't necessarily make sense to put into side by side comparisons. Some of these therapies truly are groundbreaking and provide something where the field really had nothing before, and others are just incremental.
Mhm.
And I think that makes it a little bit hard to kind of digest this. And I see this paper more as a library, and you can go kind of pull out the chapter on the disease that you're interested in, rather than pulling some conclusions from everything put together.
Agree.
So, Mandy, what do you think this study leaves unanswered? Where do things go from here?
So I have two thoughts, at least for some things to consider going forward. The data that was used was from a commercial payer, right? Optum. So my thought kind of went to, well, what does this mean for patients that are maybe government pay, so Medicare, Medicaid? Would that be translatable? How might this differ? In that. So that would be one thing I think to take if you're going to use this information and try to translate it over to, I don't want to say a different patient population, but maybe a different payer. What does that look like? And the second thing is, when pharmaceutical manufacturers, right, they negotiate with the payers, right, to get their drug on that payer's formulary. So did that have some type of influence? Because we're looking at, Optum and things like that. So I think it's just something to consider. Once again, if you're looking at different payers and maybe prescribing practices, that could influence the results of what you might see if this was run maybe on a different database. Although I agree with you, this was a large data set to go through.
Yeah, but we're looking at different drugs from different companies that had different skills in getting their drug onto the formularies of these various payers, right? And so again, it's probably little apples and oranges of different companies' skills and abilities to get into that marketplace. And I imagine just some have better people and
Mhm.
better experience and better ability to do it than others. In
Mhm.
terms of the payers, absolutely. My Medicare and my Medicaid patients have a different set of treatment options
Mhm.
available to them than my private payers. And it's hard to keep track of what they are and how they change, but they are different depending on the type of payer. And so this is just a slice of the private payer sector and doesn't include the public payer sector. Something that strikes me in the reference to out-of-pocket costs and the implication that our patients are actually opening their checkbooks and are paying these out-of-pocket costs, I think is a little misleading. And I think that's a bit of a shortcoming and a bit of a source of confusion. For multiple sclerosis, the area that I spend my clinical time, most of my patients' out-of-pocket costs are covered by the manufacturer. So the manufacturer provides rebates, provides copay assistance for that copay. So the out-of-pocket cost, well, you have to look at whose pocket it is. It's the
Mhm.
manufacturer's pocket. And I guess as they approach it, they're happy with 80%. They'd rather 100% of what they want to get, but they'll take 80% and give a rebate for that 20% copay or whatever it happens to be. So the copay assistance programs, they're very beneficial to our patients, and our patients appreciate them. They're very generous, and the qualifications are quite broad, but it does make it a little misleading as to what is the out-of-pocket cost for a drug to a patient when the patient oftentimes is not paying that out-of-pocket cost, and that's not really mentioned in the study. And I think it is an area that, as a provider, I often don't really know. I think the patient is accessing it. Often they are, but sometimes they aren't. And I later find out they're paying hundreds of dollars a month. And I say, oh, well, I thought you had access to this. We point them to it, and they do gain access and get that benefit. Um, but ensuring that they always have that benefit and access to it can be challenging. We also don't know how this might look with truly disease-shifting therapy, like a gene therapy that may really change the course of the disease, or a CAR T therapy, cell-based therapy. As we hopefully develop them and use them throughout neurology, I think these graphs will probably look a bit different. And we have to think of the things that really do change the trajectory of the disease. And I think the authors gave a little bit of a short sell to many of the new therapies that have come out, where they said, well, they aren't on the American Academy of Neurology guidelines, and so they're not really any better. Well, those guidelines take a long time to develop and to update and to get those new therapies integrated into those guidelines. And at least in MS, we do think some of the new therapies are truly better and more effective than the older therapies. And so this sort of study doesn't really take into account, well, if the drug is better, is it okay to have a higher cost for it, whether it's the full cost or the out-of-pocket cost? And maybe the utilization is too low for these truly disease-changing or these categorically more effective therapies.
Yeah. I agree with you about both your points that you made. I agree about patient assistance and copay cards. I mean, we have a dedicated, I mean, you almost need a dedicated team to help patients kind of navigate that, to
You
try to
do.
help them through that. And I also agree with you looking at what is kind of the payoff, meaning that looking at quality adjusted life years. So we'll touch a little bit about that on how maybe you can look at some of that information. So even though it may cost more, during it, the benefit to the patient, even though it's a more expensive agent. So Bob, so with this, so obviously, I know you practice in multiple sclerosis. Is this going to change anything when you see patients in clinic?
Yeah, well, at one level, I don't think this sort of study or analysis should impact providers in the clinic. When we see patients, we should be choosing the right drug for the right patient based on the efficacy, the side effect profile, the patient's previous experience with medications. And then we go about seeing what we can get covered by insurance, by their payer, by whatever source of coverage they have. Um, the out-of-pocket costs do come into play, but we typically don't know what's covered, much less what their out-of-pocket costs will be and what their copay assistance will be and all that. It's a changing amount, and this study highlights how it changes from year to year and how highly variable it is within a drug across different patients. Um, and so all of those treatment decisions are made on a sort of preliminary basis. But I don't want patients to be wondering, am I thinking at a societal level when I'm making recommendations? I want them to be thinking, and we're charged as providers to be thinking about the patient first and foremost. Now, when we wear other hats, we make other recommendations and we make policy recommendations because we don't have unlimited resources for our healthcare. But when we get into the clinic, when we sit down with a patient, we want the patient to know and to believe that we are thinking 100% about them and what is the best thing for them. And then we fight the fight to get them the medicine that we think is most effective. So it is a little two-faced in terms of what we do, in terms of when we make recommendations for policy versus make recommendations for patients. They can be different. But when we go into the clinic, we really need to be 100% thinking about the patient. Now, there was a great editorial accompanying this paper by Dr. Gordon Smith, who encourages the neurology community to consider those societal costs, to consider in that broader sense how these new and often expensive drugs fit into our practice patterns. He calls, as many others have, for a value-based pricing framework, which I think is appropriate. I agree that's necessary, but it doesn't start in the clinic. Our patients need to know that they are our foremost thought when we see them. So, Mandy, you are involved in formulary decisions and interacting with pharmacists. How do you think the study impacts formulary decisions?
Yeah. So I'm not sure that this study would really impact our formulary decision or process here within a large academic medical center. So that's the perspective that I will come from. Either for inpatients or outpatients. So our formulary here encompasses when a patient's admitted to the hospital, or if a patient would receive any medication within any of our infusion centers, with that. So, but to me, I think, as I think I stated before, this is just always a good reminder, I think, to kind of level set the cost of medications. Obviously, we need to look at the safety of a medication, we need to look at the efficacy of the medication, but we also need to make sure we consider cost. And I think, you can debate what people think about the Institute for Clinical and Economic Reviews, or ICER, but, if they are available, it's really a good idea, I think, to take a look at them. You have to kind of see what they've considered for what they feel is like the benefit versus the cost of a medication. But I just think it gives another tool in the toolbox as you're making your assessment. And then to me also, what is the true cost of the medication, right? So in pharmacy world, we have what we call the wholesale acquisition cost, which is like the price tag. Then you have contracted cost, and then you have the cost that maybe, that we're given back from the insurers. So it's all muddy. So I think you just have to be careful when you're looking at what is this particular cost of the medication. And I know in this particular article, we're talking about what is the cost to the patient for this, but that could also be impacted by what the hospital charges, what the insurance company might pay for it, things of that nature. So it's multifactorial. And then I think as healthcare professionals, with the continued rise in cost of medications, once again, I said sometimes we think we can become numb to those costs. So sometimes I just like to put it into perspective, especially if I'm dealing with newer pharmacists or maybe newer medical residents or trainees, as we start to talk to them about the costs of medication. So for example, the annual cost of a medication may be $50,000 or $100,000. And so that kind of just rolled off my tongue, but that's a lot of money, right? Now the patient
Yeah.
may not be paying $50,000 or $100,000. But in the study, we even looked at the out-of-pocket expense for eculizumab, even looking at $4,000 a month in the 95th percentile, and looking at how often eculizumab is given, that could still be upwards of almost $50,000 a year. So it might not be the cost of a house, but it might be the cost of a car. So we
Yeah.
try to give those type of examples to kind of really hit home, like, what does that mean, in terms of trying to put it into perspective. And the last thing that I have that I'll leave with is just, I don't know how biosimilars might kind of impact something like this. We have several biosimilars that are on the market, several biosimilars that could impact neurology, especially rituximab. So there's a biosimilar Rituxan, out there. And what would this do to some of those out-of-pocket expenses and standardized 30-day total costs? Because the hope when the government made that pathway in the FDA, it was to help offset some of this financial toxicity that we're talking about. But we really haven't seen the true uptake, I think, overall of biosimilars. It's still very mandated by insurance. And I think there still may be some different perceptions out there by some providers as well. So I think if you were to do this study again, maybe 5 years, 10 years from now, it'd be interesting to see how the biosimilars might impact these results.
Yeah, and I would say in the multiple sclerosis field, it's not just biosimilars, but also generics.
Mm-hmm.
So we have generic preparations of many of our previously approved branded
Mm-hmm.
drugs. And the challenge there is that now our patients don't have any copay assistance program for
Correct.
the
Mm-hmm.
generics. So
Yep.
they have to pay all of those out-of-pocket costs. Which even if the generics are at 20% of what the branded were, the out-of-pocket cost for that 10 or 15 or 20% copay is still a huge amount of money. May not quite be a car, but it's a car payment anyway,
Right. Mm-hmm.
per year, or a house mortgage payment per year, and that is a lot for them to manage. And so dealing with what happens when these expensive drugs go generic and those copay assistance programs disappear, I think is an area that needs the next area for some attention.
As a pharmacist, I agree with you. On that, we've seen that. So it may be something that the hospital, the clinic says, oh, great, the cost of this medication has decreased, right? It went generic or it went to a biosimilar. But you're right, it causes potential other issues on the patient side, just as you said, because sometimes even with biosimilars, they may not have as good of a patient assistant program, right? And as you mentioned, generics, you may not have it. So I completely agree with you that it kind of tips the scale, but maybe not in the right direction for the patient.
So many challenges remain. Well, Mandy, thank you very much for joining me here today to talk about this paper and to provide your pharmacist perspective on the prescribing patterns of new neurological medications. And I thank all of you who joined us here today watching this Neurology Video Journal Club. I hope you come back soon for another installment.